can start by saying hello to everyone and welcome to Andrew Stokes. Andrew, so we are really very honored and proud to have Andrew visiting us these 2 days and giving a seminar today. Please come in and take a seat. So Andrew, we met Andrew through the very special link that Maria Glimmour and from Boston University School of Public Health and Carole Dufouil have. Andrew is an associate professor in the Department of Global Health at the Bordeaux University School of Public Health. He's a demographer and a population health researcher. He's very much interested in studying the US mortality disadvantage compared to peer nations. So I just pointed that out because that might be, of course, or that is an interest also for more collaboration with him. And his research interests are many, but also, and he's going to show us a very good example on what the COVID left to us. And as we don't talk much about COVID still, this is a good opportunity to come back to that. He's very much interested in different approaches, traditional like demography and epidemiology, but also on novel methods for causal inference, spatial temporal modeling and machine learning. So he has a broad, really a broad topics and of interest, but also methods. And we are very much interested also for more collaborations with him. But for the time being, he's going to talk about the consequence of COVID pandemic for future mortality trends using a time series modeling approach. Andrew, up to you.
Thank you for having me. Thank you. It's such a pleasure to be here. Thank you for inviting me to the University of Bordeaux. Thank you to Carole and to Geneviève and to others for being such generous hosts these past couple days. I've really enjoyed my visit. And I don't even have jet lag because I've been here for a couple days for another meeting that we attended last week on dementia epidemiology. So I'm fresh and ready to go for this presentation. You know, none of us specialized in the COVID pandemic, right? This was a new phenomenon. We all kind of pivoted from other things, other topics. Myself, I was a mortality demographer prior to the pandemic, studying mortality and cause of death trends, surveillance in the US and other countries. And early in March of 2020, we kind of pivoted to looking at pandemic dynamics, effects on mortality, and kind of the unique ways in which the pandemic struck the United States and led to an unprecedented mortality burden, both direct and indirect. So today I want to talk about, you know, we've left COVID behind, thankfully. We're sick of talking about COVID. But at the same time, COVID has left an imprint on future mortality patterns, and it may leave a lasting legacy on US health, but also international health here in France and across Europe. And so the question is, like, how do we go about modeling and discovering this imprint? How will a pandemic as large as the COVID pandemic kind of affect trends across causes in the years and decades that will proceed? So we'll talk about that today. Part of this, you know, one of the effects that we're going to get into is kind of this idea of long COVID. A lot of research and media attention has focused on this idea of long COVID or the post-acute sequelae. So that's part of it. But we're also interested more generally in this kind of demographic phenomenon of scarring. How does a pandemic leave lasting effects on health, whether it's metabolic health, cardiovascular disease, cancers? And then there's this other piece of these profound delays in care that occurred effects on hospital and healthcare systems that may leave gaps in care for years to come. And then even more broadly, outside of the healthcare system, there are these social and economic consequences. During the pandemic, there were deteriorating economic conditions, there were deteriorating mental health, increases in evictions, increases in social dislocation, people who live alone, who are widowed or divorced, who have nobody to socialize with or to be with. And so, just beyond the kind of the health and healthcare effects, there are these broader social and economic consequences that will be grappling with for years and can have lasting effects across the cause of death spectrum. So we've had dozens of excess mortality models. Lots of teams have modeled the effects of the COVID pandemic on mortality. But what we're missing from all of this literature is any way of teasing out what were the different contributors to excess mortality. How much of the excess mortality that occurred in the US or in France or other settings reflects misclassified COVID deaths? How much of it is healthcare interruptions and delays? How much of it is social and economic consequences? How much of it are the policies themselves, the shelter-in-place policies that led to people locking down for weeks or months, right? So we have these descriptive excess mortality estimates, these impact estimates of the pandemic, but we don't know what caused those excess deaths. What are the sources of that extra mortality that occurred? So just to put some numbers on this specifically, in the United States, there were about 1.2 million excess deaths during the first 2.5 years of the pandemic. Of those, about 300,000 of the excess deaths were not attributed to COVID on death certificates. So these are excess deaths that were attributed to dementia, to heart disease, to diabetes, to other causes of death. And so that's where the real mystery lies for us as epidemiologists, biostatisticians, and demographers. What explains these other residual excess deaths that were not assigned to COVID on death certificates? And this happened in the US. It was very extreme in our country, but it was also happening across Europe. And so today I'm going to propose one statistical tool that we could use to tease out explanations and sources of excess deaths. But it's not the only tool, and I think ultimately, as we were discussing this morning with Leslie, we need to use triangulation methods to get at the answer to this through many different approaches and methods to really uncover what these pandemic effects were and what were their mechanisms. All right, so here are some of the objectives of this exercise. We want to understand the kind of the short and medium term effects of the pandemic on mortality. We want to identify the causes of death responsible for elevated mortality rates beyond the acute phase of the pandemic, and to evaluate potential mechanisms of elevated mortality rates in the acute and post-acute pandemic periods, including misclassification of COVID deaths, the effects of post-acute COVID sequelae and healthcare interruptions and delays. And this is something I would love to talk about with the French case, but in the US, cause of death certification is so fragmented, there are so many different jurisdictions coding cause of death, that there's just this huge gaps in surveillance and classification. The way in which deaths were being certified in one area were completely different than the way they were being certified in other areas. And we have this antiquated corners system in particular where these people who have no medical training are classifying deaths in many rural areas of the United States. And so in those cases, their ability to accurately classify deaths was compromised. And therefore, in the US in particular, we did have this very important issue with misclassification, which may or may not have been an issue in France. All right, so in the US, the data environment for mortality really improved by leaps and bounds during the pandemic. What was once an antiquated system that required months and months of applications turned into a real-time mortality database where we could download and extract cause of death data throughout the pandemic to monitor its toll. So we're going to use the CDC, National Center for Health Statistics data here. For developing our excess mortality model, we go back as far as 2015, and we use weekly and monthly data, cause of death, and these broad age groups from the NCHS. We also use monthly population denominators from the census with 2010 base estimates and 2020 base estimates for 2020 to 2023. I'm not sure how much you heard about the US Census, but it was a complete disaster. It was right in the middle of the pandemic. And so for those of us trying to calculate population denominators before and after the pandemic, it's been a nightmare. There's been a lot of bridging that's been required to try to get at reliable estimates of population for a recent period. All right, so we have a selected list of causes of death. Here we're focusing on a kind of a taxonomy or a hierarchy of causes, starting with all natural causes, all external causes, and then digging into more detailed natural and external causes. So we have heart disease, we have diabetes, we have Alzheimer's, we have stroke, and so on. We also have a fairly large category of ill-defined causes, which we refer to as garbage codes or unspecified. Among the external causes, we have accidents, we have suicides, we have external substances, and other external. And so we're going to kind of look at this very broadly in terms of all natural and all external, and then we'll dig into some of the specific causes of death. The methodology for this paper and for a lot of our excess mortality work has used ARIMA time series modeling, where we fit pre-pandemic baseline mortality rates for each cause of death using this baseline, and then we use that to extrapolate forward and get expected mortality rates for the pandemic period. So here we're going to go as recently as February 2023. We're a little nervous when we get to more recent periods than that because unfortunately, while the data are now real time, there are still delays and lags in reporting so that we can't really trust the most recent data, especially for suicides, homicides, opioid overdoses, and these types of deaths that require detailed adjudication by a medical examiner. So here we're gonna stop in February 2023 because we trust the data for that time period. There's a lot of discussion we can have about how far back do you go when you create an excess mortality model. Here we're going back to 2015. Some teams go back as far as 2010. Other teams only use 2018 forward. There's a lot of variation there, and unfortunately the results are quite sensitive to what you use for your baseline period. So that's something to keep in mind. So what the statistical tool that we're gonna try to leverage for this project is called cross-correlation or parallelogram analysis. And these tools are used in infectious disease epidemiology. They're also used in financial time series analysis in the finance sector. There's no real textbook for how to use these tools in public health, but there are some series of rules of thumbs and best practices that have been developed that we've kind of modeled for this exercise. And so we're going to use this approach to take weekly COVID time series and correlate them with weekly non-COVID excess death time series to try to tease out the mechanisms that explain the non-COVID excess deaths. Why were there non-COVID excess deaths from diabetes, Alzheimer's, heart disease, and what can we learn about those time series based on the COVID time series? All right. So when you take a cross-correlation for time series, any underlying trend or seasonality must be removed as cross-correlations are affected by any in-common trends the series have over time. So we use a pre-whitening step to fit a time series model to each COVID and non-COVID time series to reduce the residuals to white noise. So we're taking that kind of detrended time series, and that's what we're correlating to try to get at these mechanisms. And then the correlation between the residuals are calculated for different time lengths and plotted as parallelograms. And we've developed some theories about what mechanisms might be in play based on the different correlations that we observe. So we're going to kind of like a priori, before we look at any results, let's develop some theories about what these time series might indicate under different patterns. And so there's actually 9 different patterns that one can observe from a cross-correlation analysis. You can observe a positive correlation, you can observe no correlation, you can observe a negative correlation. That correlation can occur at a negative lag, a contemporaneous lag, or at a positive lag. And so that gives you several different scenarios that might provide insights into different mechanisms. So if we see a positive correlation at a negative lag, We would argue that that is indicative of potential underreporting of COVID, that these non-COVID excess deaths actually reflect COVID deaths directly attributable to SARS-CoV-2. If we observe a positive correlation and a positive lag, we would hypothesize that that reflects scarring or the delayed effects of disruptions in healthcare systems. So this is where COVID at a point in time is having an effect on future non-COVID excess deaths at a future point in time, 2, 3, 4, or 5 weeks out. No correlation might suggest excess not related to COVID at all. A negative correlation at a contemporaneous lag might be over-reporting or substitution effects, and a negative correlation at a positive lag might be selection. So in this case, we're hypothesizing that if COVID at a point in time is associated with less excess from other causes at a future point in time, that there's been some displacement in mortality that's occurring. All right, so here's what they are in practice. So this is what what we're doing in practice when we look at these correlations. So we're taking the weekly time series for COVID, and we're lining it up with the weekly time series for non-COVID excess, and we're calculating correlation coefficients. And so here in this little graph at the top, you can see what that looks like in practice. You see a strong positive correlation at a lag of 0. If we're looking at a lag of positive 1, here the correlation between observed COVID and non-COVID excess in the following week. So here we're staggering each of the non-COVID series 1 week after the COVID series. So we're saying COVID at a point in time, non-COVID at a future week in time. And we can do this at +1 week, but we can also do this at +2 weeks, +3 weeks, +4 weeks, for as many weeks following the COVID time series as we wish. Here's what happens when you look at a negative lag. So here we're taking the COVID time series and relating it to the non-COVID excess time series the week before. And again, you can generalize this and look at even more severe lags. All right? So does everyone feel like they have a sense for the method? Do you have any questions about that before we move into some preliminary results? Yeah, it's pretty straightforward once you see it as a picture. All right, so we're going to start by just looking at some ARIMA modeling results. Not sure if this is true in France, but in the US we see residual excess mortality. We see, let's say, sustained or persistent excess mortality even into the most recent period we looked at. So if we, in particular, if we look at 0 to 24-year-olds and 25 to 44-year-olds, observed mortality is still higher than mortality that would have been expected based on pre-pandemic trends. And that's a very concerning finding, particularly when it occurs among youth and young adults, that there's been some discontinuity in the pandemic that's triggered a persistent or continued increase in mortality, even through the post-pandemic period, even into 2023. The good news, though, perhaps, is that at older ages, we do see some evidence of convergence, such that the excess mortality that was observed through much of the pandemic appears to have diminished. However, we'll have to confirm this with more recent data. All right? All right, so here's what it looks like when you dig into causes. We're going to start with the broad hierarchy of causes, just looking at all causes, natural cause excluding COVID and external. The big story here is that the persistent excess mortality that's observed in aggregate is particularly manifest in these external causes of death. So for external causes of death, we see continued excess mortality even into 2023. This includes accidents, overdoses, suicides, and deaths of external means. For natural causes, we see some evidence of a convergence, diminishing excess mortality in the most recent period, but again, we'll have to confirm that with the most recent data. I've looked a little bit at the kind of similar results for the UK, and the UK also appears to have some residual excess in the most recent period. We haven't yet looked at French data, so I'm not sure how this looks in France, but I would love in the Q&A or after the talk to to engage with anyone who's looked at this data using French mortality files. All right, so this is small, but this gets into more detailed causes of death. And I want to immediately bring your attention to a puzzling finding in the lower left corner, namely accidents, motor vehicle accidents, are way above pre-pandemic trends and continue to stay elevated even in the post-pandemic period. We're still seeing much higher rates of motor vehicle accidents in 2023. And so that's a very puzzling finding that would require some real teasing out. In terms of other causes of death, we see continued excess occurring in other natural, which includes some drug poisoning deaths and other causes, so that's another puzzle to work out. And then we see some evidence of continued excess in some of the metabolic causes, but not all of them. Some of the bigger categories, like if we take stroke or Alzheimer's, it appears that for those we have returned to baseline. And you know, I'll foreshadow this now and we'll come back to it. If you look at dementia and Alzheimer's specifically, observed death rates are actually now a little bit below expected death rates, which might get at this selection hypothesis that we're going to return to when we talk about the correlograms. The selection hypothesis being that COVID was so deadly in this age range that it may lead to less Alzheimer's deaths in the months that follow due to selection out of the cohort. All right, so let's get into the correlograms. So here's a correlogram. We'll start simple with correlograms for natural cause excluding COVID and for external. Here, the gray window, the gray box, is the kind of the window delineating significance. So anything kind of outside of that gray box is statistically significant. Anything in it is not. So here we find one pronounced statistically significant correlation at a lag of 0 for natural causes excluding COVID. So what does that mean? It means that COVID deaths at a point in time are predicting non-COVID excess deaths at that same point in time within the same week. And because there's such a strong contemporaneous association within the same week, we think that that's strong and compelling evidence that that's simply misclassified COVID. If it were anything else, we would expect some type of lag to be manifest. But the fact that it's happening so contemporaneously within that same week provides some evidence that this is just spillover of SARS-CoV-2 to other causes of death in this larger landscape of US mortality statistics where the cause of death coding is not done very well, right? What do you also see here? You see for external deaths, these are suicides, homicides, accidents, external causes, no correlation with SARS-CoV-2. Makes sense, right? Because you wouldn't expect, a priori, you wouldn't expect spillover from the SARS-CoV-2 virus to external causes of death. You may expect some global effect related to policies or to social and economic consequences, but those wouldn't be related to the spatial temporal dynamics of SARS-CoV-2 itself. Just like in France, we were having a conversation yesterday that when France entered shelter-in-place policies, that those were not spatially and temporally located at the same time that COVID was peaking. Everywhere in France was implementing these policies, even outside of the zones where the pandemic was most fierce.
Can I ask a question?
Of course.
Are external causes more frequent with earlier age of death?
Absolutely, yes, yes.
Could that explain that there's no...
It's an interesting question. So we can break down these statistics and look at external and natural for each age category to really dig into that. So some of this could be age, but a priori, I think one could make an argument that if we believe this is misclassification in the first case, it almost seems implausible that COVID would be misclassified as a suicide or as a homicide or as a motor vehicle accident. So I think this kind of broader story we're telling around misclassification probably doesn't apply to the external causes, which might help to explain the lack of a temporal correlation. Here's some of the natural causes in detail. Take a look at Alzheimer's disease. I know that's one that some of us are passionate about. So there is an association with Alzheimer's disease. There's an association at lag of 0, which suggests this misclassification mechanism, but there's also a positive association at lags of 1 and 2 weeks, suggesting that COVID at a point in time is predicting Alzheimer's deaths 1 to 2 weeks later, which we argue, could relate to these kind of synergistic effects of the two, or these post-acute sequelae that's, where COVID can exacerbate the conditions of someone with Alzheimer's and lead to a death 1 to 2 weeks later, or it could be due to healthcare interruptions and delays causing elevated mortality in people living with Alzheimer's disease and related dementias. And you can see here for cancers, the same pattern, except for cancer, there is a negative correlation at a positive lag, which means that COVID at a point in time is predicting less cancer 4 or 5 weeks later, which is consistent with this kind of selection idea that if you're living with advanced cancer, you may die of COVID a few weeks earlier and then therefore be less likely to die of cancer a few weeks later. So there's some mortality displacement happening where those who would have died from cancer instead died from COVID a few weeks earlier. Here's a couple more. Similar patterns: heart disease, stroke. For influenza and pneumonia, we see some evidence of selection again with this positive correlation and a negative lag. And for chronic lower respiratory, we don't see too much happening at all. Here are some of the external causes. Here we don't see much happening. We basically see null associations across the board, which again makes sense if we believe that misclassification would be implausible for these external causes. So here's the story by age. So what we see by age is a more pronounced pattern around mortality selection at older ages than at younger ages. So at the oldest ages, we see that COVID at a point in time predicts much less mortality from other causes at a future point in time, which makes a lot of sense given the high degree of vulnerability of older adults during the pandemic and the large extent to which their mortality rates were exponentially higher. And so this kind of mortality displacement phenomenon really shows up here in these negative correlations at positive lags. And you can see those negative correlations at positive lags, you really don't see any significant findings around that for the younger age groups. So it really only starts to emerge in those who are 85 plus. Here for external causes, we don't see much of anything happening. All right, so some key takeaways. Across most natural causes of death, we find that increases in reported COVID deaths correlate with increases in excess deaths reported to non-COVID natural causes in the same or subsequent 1 to 2 weeks. These temporal associations do seem to suggest that underreporting or misclassification is an important mechanism, but not the only mechanism. Some excess deaths may have also been attributable to the post-acute sequelae of COVID and to healthcare interruptions and delays. By the way, when we break up the correlograms by year, we use pandemic year 1, March to February, then pandemic year 2, March to February, and pandemic year 3, March to February. These patterns of positive, strong associations go away in year 3. So it seems like whatever misclassification was occurring between COVID and other causes of death was basically mostly in year 1 and year 2. By year 3, it seems like the issue was mostly resolved. At older ages and for selected causes of death, the findings suggest an important role in mortality selection. So for cancers and at older ages, particularly those who are 85 and above. And the lack of correlation between COVID and external deaths suggests that indirect mechanisms may be at play in producing excess deaths from these causes. So, this is not to say that COVID is not having an effect on these external causes. It's just probably not mediated through the virus itself, through SARS-CoV-2 itself. It could be mediated by broader policies or programs or interventions, but those were not temporally and spatially correlated with SARS-CoV-2 itself. All right, so I just want to thank my collaborators who are from Boston University as well as the University of Pennsylvania and the University of Minnesota. This work was sponsored by several foundations, including the Robert Wood Johnson Foundation, the Kellogg Foundation, and the Society for Actuaries. And this little sub-project that we're doing on COVID death counting and COVID death mechanisms is called the Uncounted Project. So at this point, I kept it short so we'd have lots of time for Q&A. So at this point, I would welcome a discussion. Thank you.